Hello everyone, welcome back to the channel Essentials of Acute, Emergency, and Critical Care. Today, we will discuss an important and often confusing cause of hyponatremia in neurocritical care patients, cerebral salt wasting or CSW, and more importantly, how to differentiate it from syndrome of inappropriate antidiuretic hormone secretion or SIADH. This distinction is absolutely critical because the treatments are almost opposite. Misdiagnosis can worsen neurological outcomes and potentially be life-threatening. By the end of this video, you will understand what cerebral salt wasting is, its pathophysiology, diagnostic criteria, the key differences between CSW and SIADH, and management principles. Let's begin. Cerebral salt wasting is a syndrome characterized by hyponatremia, excessive renal sodium loss, polyuria, and extracellular volume depletion. It occurs in patients with intracranial diseases such as subarachnoid hemorrhage, traumatic brain injury, intracerebral hemorrhage, brain tumors, meningitis, and neurosurgical procedures. The condition was first described in patients with subarachnoid hemorrhage, but we now recognize it in various neurological disorders. The incidence is highest in subarachnoid hemorrhage, where studies suggest it may occur in approximately 10 to 25% of patients. The exact mechanism is not completely understood, but two major pathways have been proposed. Mechanism 1. Increased natriuretic peptides. Brain injury causes increased release of brain natriuretic peptide and atrial natriuretic peptide. These hormones increase urinary sodium excretion, promote diuresis, and suppress renin and aldosterone secretion. As a result, the kidneys lose sodium and water, leading to hypovolemia. Mechanism 2. Sympathetic dysfunction. Brain injury may also decrease sympathetic stimulation of the kidneys. Normally, sympathetic activity promotes sodium reabsorption and renin secretion. Reduced sympathetic activity causes reduced sodium reabsorption, further natriuresis, and additional volume depletion. Therefore, the hallmark of CSW is primary renal sodium wasting leading to hypovolemia and secondary ADH release. Patients may present with symptoms related to both hyponatremia and hypovolemia. Manifestation related to hyponatremia are headache, nausea, confusion, seizures, and reduced consciousness, while hypovolemia may cause tachycardia, hypotension, orthostatic changes, dry mucous membranes, reduced skin turgor, weight loss, negative fluid balance, and elevated blood urea. However, in ICU patients, assessment of volume status can be challenging. Typical serum findings include sodium less than 135 millimoles per liter, low serum osmolality, increased BUN to creatinine ratio, elevated hematocrit due to hemoconcentration, and low uric acid. Urine findings are urine sodium usually greater than 40 millimoles per liter, concentrated urine, urine osmolality greater than 100 milliosmol per kg, and high urine output. Concentrated urine means that the urine has a high osmolality, despite the patient producing a large volume of urine. At first glance, this seems paradoxical because we usually associate polyuria with dilute urine. However, In CSW, the urine is not dilute because the kidneys are excreting large amounts of solute, especially sodium. Unfortunately, these findings overlap considerably with SIADH. Therefore, differentiation requires careful evaluation. Both CSW and SIADH produce hyponatremia, low serum osmolality, high urine sodium, concentrated urine, and low serum uric acid in the setting of neurological illnesses. Then how to differentiate? The major difference lies in the patient's volume status. Step 1. Assess volume status. Cerebral salt wasting. Patient is hypovolemic, negative fluid balance, weight loss, tachycardia, orthostatic hypotension, and possible low CVP. SIADH. Patient is euvolemic or mildly hypervolemic, stable hemodynamics, no signs of dehydration, and no significant weight loss. Remember, CSW is salt loss and volume depletion. SIADH is water retention without significant edema. Step 2. Look at urine output. CSW, usually associated with polyuria, high sodium losses, and negative sodium balance. SIADH, typically normal urine output, sometimes reduced urine volume. This difference can be extremely helpful in ICU patients. Step 3. Evaluate fractional excretion of uric acid. Initially, both disorders have hypouricemia and elevated fractional excretion of uric acid or FUA. However, after correcting sodium, SIADH, FUA returns to normal. CSW, FUA remains elevated. Persistent urate wasting strongly supports cerebral salt wasting. Step 4. Response to treatment. This is often the definitive differentiator. If you give isotonic saline, cerebral salt wasting, sodium improves, volume status improves, ADH stimulation decreases, and hyponatremia corrects. SIADH response to isotonic saline is different. Hyponatremia may worsen, excess water is retained, and urine remains concentrated. This explains why giving fluid restriction to a patient with CSW can be disastrous. Treatment goals are 1. Correct volume depletion by isotonic saline administration. Monitor fluid balance closely. 2. Correct hyponatremia. Hypertonic saline if severe symptoms occur. Avoid rapid correction. Target sodium correction generally less than 8 to 10 millimoles per liter in 24 hours. 3. Replace ongoing sodium losses. Salt tablets or enteral sodium supplementation. 4. Consider fludrocortisone. Dose 0.1 to 0.2 milligrams once or twice daily. Fludrocortisone promotes sodium retention and may reduce fluid requirements. Monitor patient for hypertension, fluid overload, and hypokalemia. Let's summarize. Whenever you see hyponatremia in a patient with acute brain injury, always ask, is this SIADH or cerebral salt wasting? Remember these 3 points. CSW is hypovolemic. SIADH is euvolemic. CSW has ongoing renal sodium loss and often polyuria. Treatment is opposite. CSW needs fluid and sodium replacement, whereas SIADH usually requires fluid restriction. Recognizing this distinction early can significantly improve neurological outcomes and prevent inappropriate therapy. Thank you for watching. If you found this video useful, please like, share, and subscribe for more evidence-based critical care videos for doctors. See you in the next video.